aspirin is a cornerstone of therapy once somebody has MI, and particularly for those patients who have undergone PCI and stenting. Now, if stopped prematurely, it can lead to a lot of problems, such as MI, thrombosis, death. We are with Tracy Wang from Duke University, who's an associate professor there, coming up in the April 29th issue of JACC. And I got to get the title here because this is from Translate ACS. It's data called Early Post-Discharge Bleeding and Antiplatelet Therapy Distinguished Among Acute MI Patients Treated with PCI. This is a tough setting, and these people really are, they do benefit from aspirin, but then the issue is bleeding.
Exactly. So we found a problem, a somewhat big problem. We found that among about 9,000 or so patients who had an acute MI, who underwent a PCI, so now they require dual antiplatelet therapy, and by guidelines, they need to be on dual antiplatelet therapies for ideally 12 months or more, that quite a few of them actually develop bleeding. So 1 in 7 of these patients will have some form of bleeding. Now the good news is not all the bleeding is severe bleeding, so not all of these required going into the hospital again to be retreated. The other piece of good news, I think of this as a silver lining, is that we so far are doing a great job of telling our patients, listen, you're on these therapies and you need to stay on these therapies, because only a very small fraction of these bleedings have actually led to premature discontinuation.
So the number is high, but the actual serious ones are really low.
Exactly.
And that is encouraging.
It is encouraging. There are still some areas we need to focus on a little bit more, though, because more than a quarter of these premature discontinuations were in patients who have drug-eluting stents. Now, as you know, drug-eluting stents really requires that long duration of dual antiplatelet therapy. So even within the first 6 weeks, even though the number of patients who stop their antiplatelet therapies is pretty low, there are still a good number of those stoppages that the patient didn't talk to their clinician about it, and they stopped it without letting their physician know, but in a situation where they really shouldn't be stopping it. So this is still a very critical problem for us to continue to focus our attention on.
I mean, there was also another study recently, and I think it was in JACC, that was taking a look at premature cessation of therapy, and they were showing that if it's stopped by a cardiologist, the risk is pretty low. If it's stopped by the patient, the risk is much higher for a variety of reasons. How can you stop the patients from taking their aspirin therapy?
Well, that kind of makes sense, right? If we, as a cardiologist, made a decision to stop it, we have hopefully taken into account the patient's risk for life-threatening bleeding or very severe bleeding versus the risk of actually, stopping the antiplatelet therapy when ideally we'd like to continue it. And we can come to a happy medium there. For many of the patients who had bleeding in Translate, we found that almost half of those, they never actually reported it to a clinician. So if a clinician doesn't know about it, then they can't help the patient make the decision to stop. The other thing we found was that if patients had an early follow-up appointment with their physician, they were less likely to stop prematurely. So that's a very key point, is if we arrange adequate close follow-up of the patient, we can screen for these kind of bleeds. We can help the patient triage what's severe, what's not severe, what we can live with. Hopefully we can negotiate that a little bit. But most importantly, we then can help the patient not run into a situation where they should be on antiplatelet therapy, but they stopped it for what they think is, a nosebleed or something that, is on the severity scale not as bad as stent thrombosis.
Right. At Duke University, what do they do in terms of trying to educate their patients? Is there paper? Is there actual contact with a clinician before they leave?
We do a lot of things, actually. So our traditional thing, I think most hospitals do this, is we obviously send patients home with a lot of a binder full of nice materials, and I'm sure the patients go home, put it on the kitchen table, and go about their regular life. Some of the new things we've been doing lately is we actually call the patients at home 3 days after they've left the hospital. This is a new thing that we've implemented over the last year or so, and we found this to be very effective because we can do more education. We actually probe the patients for any symptoms. We review their medications with them. We remind them about their follow-up appointment, and we look for gaps that we might have missed in that whole transition process. Right. And we found that that's helpful, at least We haven't, we're still in the process of collecting data to see if it actually improves patient outcomes, but our patients have really expressed a lot of appreciation for that sort of extra hand-holding. The other thing that we've done is we've made sure all of our patients, 100% post-MI, will get a follow-up appointment within 2 weeks. Okay, and that's both the, following up within our Duke system, or if they're transferred in from somewhere else and they're following up somewhere else, we actually try to contact that physician's office before they even leave the hospital to make sure we've got a date and a time for the patient to show up for their follow-up appointment.
Really good.
So I don't think these are unique to Duke, but these are the things that we're working on very hard to make sure that our MI patients get good transition of care.
Now the paper again is coming out of the April 29th issue of JACC. It's from Translate ACS and for Cardio Source World News. I'm Executive Editor Rick McGuire.